Japan also, and my project was about the genetic mechanism of vancomycin resistance in Staphylococcus aureus. So
You'd like to
I'm very
speak
much
into the
familiar.
mic if you.
I think it's
It's not working.
Oh, it's not working now. So I just wanted to know that what are the what is the status of antibiotic stewardship in Indian scenario? What is actually happening here? Because I know there is no data about the EMR status. So what is the stewardship steps adopted by the hospitals and the healthcare systems?
Okay. Maybe another one or two questions. If there are any related questions, otherwise we'll ask Wong to respond to it. Anita?
Hi, am I audible? I'm Amitabh Sarkar. I just submitted my PhD at the Center of Social Medicine and Community Health, JNU. Thanks to all the presenters. I have questions which actually was given come from the hint the discussion said regarding the social and economic determinants, socio-economic determinants. My point is, in India recently, the government of India for last 3 years, they came up with this FASI, Food Adulteration for Safety and Standards Institution and Act, something like that. Now, say even the One Health approach, at one point for the cultural and socio-cultural reason, this particular subcontinent is depending on animal product heavily. At the same time, the over-medicalization and informal access to drugs are huge. Now, at one point of time, Dr. Wong, you are talking about the surveillance. Most of the countries in LMIC, including the 11 countries except the South Korea, mostly data comes from, or data is based on facility based. They are not community based. So all the, even the HMIS management and entire system. And facility based, that too only for the public hospitals, not the private hospitals. Now, so it's just probably, minuscule, whatever is happening. The question I actually now take it from his presentation, that or continuously you were saying there was the methodology. I just, as a public health worker, I'm just thinking that probably the system research on this issue may be of help to understand what is the interaction and how what the reciprocity between, say, human lives, animal products and the environment, and accordingly if you come up with that. Otherwise the trend from Dr. Sorry, I didn't get it. You're talking about the stewardship. Now stewardship, basically it means the government to steer the private sector or the operator, be it public or private. Mostly these days, especially for the curative care, it's a trend that government is going towards the private sector to buy or purchase care, if not services alone. Now the point, say I just take this opportunity about this stewardship. Where is the regulation or even the Medical Establishment Act? Are they compelled to or adhere to the say AMR resistance issues or the over medicalization issues? Mostly, even Indonesia, especially Indonesia and India, the Medical Establishment Act are dealing with the cost and the quality of care, but they are not talking about the STG, and even the STG, within the STG, standard treatment guidelines, even within the STG, it's only about the procedures. So obviously whatever we have come across, these are needed because to surveillance and data monitoring, but how to monitor and the methodology, because it was not there, or it is coming up, evolving, but what is the system we are considering, and then AMR, and then to have data as well as action plan on AMR. Thank you so much.
Okay. Dr. Wong, maybe you respond to her question first about India's response and the data that we have from India.
because it was about the consumption of antibiotics.
stewardship.
Stewardship, yeah, stewardship. The situation, I can add to, but it's more her area, so I'll leave it to her too.
Well, what I know from our country office colleagues and what I understand also from just looking at the literature, we have done a systematic review of looking at published papers where hospitals or provinces or different states would have collected data on and tried to look at certain interventions under antimicrobial stewardship and also measure the consumption. Is very patchy. It's very sporadic. We don't see an overall clear policy. India does have a very comprehensive national action plan on AMR, which lays out the big picture and follows the WHO global action plan. So gives direction and gives sort of aspirational goals. But the process of translating this national action plan to actual national guidelines, training programs, putting into the curriculum and training of in the pre-service or in-service training of the physicians, nurses. I think this is a long way to go still that will have to happen. Antibiotic treatment guidelines are published in all sorts of different states, different universities, different teaching hospitals, and we know that there are some good sort of foci. Some teaching hospitals, some universities have some good programs where they demonstrate that a multidisciplinary team can deliver stewardship program. But these are still, as I said, very fragmented, and they are not actually scaled up on the national level. I think it's an urgent task. It's a difficult task, obviously, with the large scale. And I think it's definitely we would have to go down to state level. It's although the National Action Plan is an overall central level global plan for the whole of the country. But we need to see now that each of the individual states, how they would issue their own guidelines, procedures, create the governance structures, create the budget. And just to give an example that how these things, we say that it's big and complex, but often big and complex things can get started with a small step and a small investment. I visited and we had our regional workshop in Bhutan earlier this year. And Bhutan in the central hospital has an excellent stewardship program. I mean, it's so impressive that we had visiting professors from the US and they were finding that certain things what Bhutan was doing, they themselves have not yet implemented. The whole thing started with the commitment of the hospital director who was willing to create one position, a clinical pharmacologist, a physician, whose full-time job is to actually run the stewardship program. This stewardship person, this medical doctor, very motivated, she trained the pharmacists and she set up a system like restrictions that you cannot get cholesterol, carbapenem, meropenem, I mean the high-level cephalosporins. They put them into a separate pharmacy and you cannot get it dispensed unless she signs on it and the senior infectious disease specialist signs on it that this patient really needs this, and they attach the laboratory results to show that they have a drug-resistant infection. She set up a system just simply using WhatsApp. I mean, not WhatsApp, but WeChat, because they're close to WeChat, to China, so they use WeChat more. To get the lab results, as soon as it's out of the machine, the lab technician send it to her, so she can WhatsApp it or WeChat it to the physician and discuss immediately and have point of care level interventions. Now, I think these sort of small steps have to happen, but it really has a major dependence on the hospital management and the hospital director leadership. Obviously, hospital directors need to be motivated and given the resources. So this person was obviously had the salary that they can do this. But I think we have to start to this sort of small step and scale up and start to work with some of those good centers, which we do have a couple of hospitals around India, which started and trying to implement these practices. But the big challenge will be that how we go to full scale and have it happening in every single hospital eventually. So that's just on the stewardship.
Yeah, I mean, I totally agree with you, and I would just want to add something. I get blamed all the time. I tend to look at the the glass half empty and not the glass full. So I will compensate on the fact that it's very complicated and it's very challenging. If you're asking me whether we're winning that battle against antimicrobial, we're not winning it. And we're not winning it if you look at the situation of India, for example. It's a huge country, etc. But when your question is about stewardship, you may think about stewardship in the hospital, but we're talking about also stewardship in the national level. Basically, the policy is the policy there. In India, you have a huge, nice document that tells a lot about policy. But it's at the federal level or union level. But health is decentralized at the state level. So how are you going to move from union level to state level? It's up to the state level. So it's a barrier already. Now, when you talk about stewardship at the national level or state level, if there's one, Kerala has one, but are all hospitals adopting it or all healthcare facilities adopting it? No, because each facility has its own stewardship program. And she mentioned examples. But this is a small drop in the ocean. It's very complicated. Then what I'm talking about human sector, but how about the animal sector? Stewardship in the animal sectors, policies like, we need to ban growth promoters, instead of giving antibiotic like this, you need to regulate it, and it's very complicated. We have that now. India has banned growth antibiotics as growth promoters. That's beautiful, but how about the enforcement and implementation of it? It's a huge issue. Environmental, the same thing. So it's, you put that together, where are we? And the huge problem that India has is two things. You might think that you want to reduce antibiotics in India, it's fine. But here, antibiotics are very cheap. So even antibiotics in human sectors are bought from the from the agriculture sector to give it to animals because it's so cheap. So you feel like, you want to reduce antibiotics in India. But there's another dilemma. There are areas in India that don't have access to antibiotics because they don't have medical doctors. And when you say, only doctors are to prescribe antibiotics, you have areas of India where you don't have doctors. So how you handle this? So these are the things that we're here for the long run. So, and I hope it gives you the complexity of the problem, and then it's just like how we start, as she said, one by one.
Excuse me. Yeah, this is a very serious problem here because I did a study. I surveyed. I collected some samples from AIMS, which is very known hospital in India. I think this is the best healthcare facility in India. And when I wanted to publish the paper or write the paper to report something which is like I observed a high multi-drug resistance in hospital OPDs and surgery wards. Then they said no, you can't publish and you can't put.
Yeah, that's
can't
another
give the
issue.
name of the hospital. So people are so wary of these revelations. So how can we tackle this problem in the farmers who are not literate, who don't know even the AMR, and so this is very difficult to handle in India especially.
It's behavior change.
Yeah.
But behavior change means that you need to have data to show, but you need to have champions. You need to have leadership. Now, at the higher level, you have commitment of India to tackle it, but how about the agriculture sector? So, all these things has to be taken all together. It's very complicated. It's definitely a big issue.
If I can take us back to Amitabh's question, since he pointed out also the complexity of the medical care system itself, that the large informal sector that exists, and if we only keep it at hospital stewardship programs, then probably that's not the answer for India.
No.
So how would you look at that? How are you, proposing that the government of India tackles that?
It's, as it said in the Global Action Plan, I really like that document, and I really advise you to read it because they're very comprehensive. And the whole thing is about the concept of multi-sectoral, transdisciplinary, all levels, and it has to be tackled all everywhere. And you are more focused on the determinants from the environment and sociology. It's behavior change, and you know how complex it is to to change behavior in the population. You can do it and it could last to a couple of years, but how about the long-term thing? So altogether, we're in here. And for the environment, for example, this is something that is very important for India because we have Swachh Bharat program, and Swachh Bharat program is something that to me is very important because you were talking about the incidence of infection. And I don't know whether you're familiar with that beautiful paper. Actually, it's a very colleague of mine when I was at US CDC. The author is Greg Armstrong, and it was published in 1999 by CID, Clinical Infectious Diseases. And it shows the curve of the incidence of infectious diseases in the US. It started, the drop of the incidence of infectious disease started before the introduction of penicillin, and you're familiar with that history thing. So, and why is it? Because it's the progress in the hygiene and environment. So, so this is a big, huge thing that is going to change. And then that we have a hygiene and environmental problem in India that needs to be tackled. So it's an issue to me that is very important. And of course, working on how to overcome barriers for behavior change. This is something that is very important as well. I mean, always surprised to me that India is doing very well for tobacco control, but we're not doing very well in hand hygiene. So these are the things that in the environment sector as well. So just something to bring in that it has to be all together.
I have a
Good.
one
Yes, please.
comment on that really.
If you could press the big button. Yeah.
Okay, it's okay.
Oh, okay.
As Sirendra mentioned, it's really a complex and complicated area. And really we talk about the legislation, regulator and the provider, but there are a lot of facts from the demand side. So we always think about the supply side. Now, in terms of the stewardship, as you nicely mentioned, it's the drop of the whole ocean. But now we are really thinking about the hospital-acquired infection, but there are community-acquired infections for which we need to adapt another strategy. Now, currently, what we really do with the policy level, how we can really do anything on that. But there are a lot of things should come from the community level, for which, as you mentioned, you need to have a sort of a collaborative action, but it's not that easy. For instance, like the big countries like India, where they need to do a lot of initiatives. Now, there are some initiatives very cost effective, for instance, the hand washing. It can be adapted in any stage, but not adapting. Now you need to have the attitude and perception about the importance of the hand washing. And more or less, if you go for the other extreme, if you ban antibiotics or the high profile antibiotics, third generation or fourth generation antibiotics, only to the pertaining to the doctors or clinicians, there will be an issue. But balancing those factors, what I suggest for countries like India, they need to have a good governance and leadership in terms of looking at the whole health sector in the holistic manner. If, for instance, you can't really work only with the health personnel. You need to have some other categories as well. This AMR is not as he nicely mentioned, it's not a health issue here. Yeah, it's a multi-factorial. Therefore, everybody should understand it. But I think it takes little time. This particular AMR concept came within last 2 decades. So I think if we wait for another few years, we can see sort of latest any development. But from the administrative level or policy level, need to do some critical implement some critical decisions.
Thank you. Dr. Clara?
Yeah, just want to add a little bit. I think it's really important to look at, as I said, that beyond the nice word, and there was a recent publication by Chatham House the ONI report, which has estimated 2 years ago that what is the number of deaths. And then they looked at the progress on AMR, and they pretty much say that there is dismally low. There is very little happened in the last 2 years. A little bit happened on the animal growth promoter ban, and on surveillance, lots of the donor money was invested, but otherwise it's pretty low level action. And I think, I mean, some of these social determinant issues obviously absolutely essential, and the government has to look at it, that how with vaccination, hygiene, infrastructure, hand washing, the Swachh Bharat, you can, if you reduce infection and you reduce the use of antibiotics, you can reduce the antibiotic pressure that create resistance. But I think on the other hand, our major task, and this is where the behavior change, what Sirenda meant, that when we do awareness raising on these issues, how we can actually achieve behavior change. So for example, how many of you have children already? Anyone who has children? Yeah. Okay.
You're
How-
very young.
How many, and those who are planning, can you see a future for your child? Can you see you bringing up your child without ever giving her antibiotic? Is it possible to bring up a child in India to be a healthy adult without an antibiotic?
Yes.
You can,
So far they're 3 and 2
and you haven't been even, you haven't given them antibiotic. Very good. Anybody else?
Well, I have a 14-year-old and she's never had an antibiotic.
Yeah.
14-year-old.
No way.
Very good.
Excellent.
Very good.
Which you
Yes,
grew up
I
in.
have a 25-year-old
Yeah,
daughter.
but
She's not
she's
had
in
antibiotics in
India.
18 years.
Yes. So this is what I'm talking about, awareness raising and behavior change. This is exactly what we will need to take the whole population. I lived in the Netherlands for a year, and I met generations of young people, 25, 30 years old, grown up, ever taken any antibiotic in their whole life, and they are raising now their children without, obviously, the hygiene, the socio-economic status, the housing where you live, you are able to do that. But we need to let people know that it is possible, and they can prevent themselves from infection, and they can do this. On stewardship, I think there is also huge opportunities in India. India is at the moment in a really historical moment with the Ayushman Bharat and the Health and Wellness Clinic program, with the biggest investment in the whole world, what the Indian government is doing in health. Now, AMR has to be a priority as part of Ayushman Bharat in the performance indicators of the providers, in the health and wellness clinics. Who will be delivering care? How are we going to train them? Can we train them, and can we have a standard treatment guideline for the health and wellness care clinics and say that they're only allowed to use 3 antibiotics